COVID-19 presents a very clear threat to our society and the way we live. For Black Americans, that threat is more serious. Here's how the CDC puts it. Long-standing systemic health and social inequities have put many people from racial and ethnic minority groups at increased risk of getting sick and dying from COVID-19. The decision to get vaccinated is a very personal one, but you don't have to think about it alone. It is important that we come together as a community to address this threat. Our intent with this community town hall is to get you the information, create a forum for you to discuss your concerns and ask your questions. Tonight, you'll be able to leverage credible community subject matter experts to help you make an educated decision on what to do for you and your family. Because when you know better, you do better. We are in this together.
Dr. Becker, you can start with your intro.
Good evening, everyone. Thank you for your patience. I am going to, can you hear me? Can you, I hear echoes from, hold on one second. Okay, sorry about that. Thank you so much. So we're gonna start with our Black anthem, actually, the national Black anthem. Marshall Keys is a saxophonist, great artist, and I don't see him quite yet, but I believe he's on. There he is. So if everyone could just stand or sit in silence. Thank you. society.
Hi. Good evening, everybody. This is an excellent time for all of us to realize that working together in a collaborative manner, we are able to provide effective communication through medias and social media to inform individuals about the importance of vaccination. I welcome all of you to this particular town hall meeting on behalf of Morgan State University, President David Wilson, Provost and Chief Academic Officer Lisa Crampton Young, Dean of School of Community Health and Policy, Dr. Kim Signor. We are actively involved in several initiatives related to the same subject matter. And we're also getting ready to start a Pfeiffer education grant, not advertising Pfeiffer itself, but to a Baltimore community and part of Washington, D.C. We are particularly proud to be a part of this collaborative initiative and working with ARC as we move forward to bring about change, effective change, through education. Part of what we're doing here at Morgan State University is that we're very active and from the Office of Global Health Initiative and working with an MOU that's been signed with HBCUs and PPIs to actually look at, and this is in reference to a committee that I'm chairing under that MOU, medicine, health, science, biomedical care, and in health system strengthening and capacity building. All around the idea that we need to educate the community in reference to what is happening both locally and globally in the healthcare system arena. The term we use at Morgan State University that I've coined from a Japanese term is globalization, that we can act locally and have a tremendous impact globally. And we are doing that at Morgan State University School of Community Health and Policy, Office of Global Health Initiative, of which I'm serving as the consulting coordinator. We're in Haiti, we're in Mozambique, we're in the process now of getting ready to do some services in South Sudan. We already have several programs going in Nigeria. We are very serious because what we want to do is to make sure that we bring forth, and I think this initiative will also aid us in this as we continue on, a knowledge base for individuals in the healthcare arena, that we want to have a new generation of healthcare leaders, practitioners, policymakers, advocates, and communication experts. On that note, I would say welcome, and I'm pleased to be a part of this collaborative initiative.
Good evening, everyone. Thank you to the panel for joining us this evening. Thank you for you in the audience for joining us as well. My name is Dr. Bradford Wilson. I'll be your moderator for the event this evening. And first off, we're going to start off our first segment by looking at some of the current information regarding COVID-19. And currently we know that the situation regarding COVID, there have been over 28 million reported cases in the United States, with unfortunately over 500,000 deaths here in the US. With regards to testing, over 327 million tests have been administered in the United States, with over 29 million positive tests, with an overall positive rate of just over 9%. So we also know that there are certain conditions that predispose individuals to infection and severe illness from COVID, and those include many health disparities, And with that being said, we want to segue into our first question of the evening to our panelists regarding and we like to take this time to let them introduce ourselves to you and provide some information on their background and propose an answer to our first question of the evening, which is related to, and that question is, would you please share your institution or organization's efforts to educate and or engage high-risk populations in addressing the predisposing health disparities or inequities in healthcare? And we can start off with Dr. Tiffany Gray.
Good evening, everyone, and thank you for having me. I'm Dr. Tiffany Gray. I am a public health advisor at the DC Department of Health. I like to say my typical normal day job before COVID, I work as a public health advisor for our tobacco control program within our Cancer and Chronic Disease Prevention Bureau, and has been detailed as part of our COVID-19 response efforts since early last year. And I can just speak generally to some of the work that DC Health as an agency does in order to address some of the pre-existing health disparities throughout the district. We have various agencies with various programs that work very closely with many of our community partners and community organizations to ensure effective programming and communication around key areas of health, including immunization efforts, nutrition and well-being, healthcare access, as well as screening for many chronic illnesses and diseases. And so DC Health as a whole has continued those efforts to ensure that they're continuing those same delivery of programming and services throughout the district, and ensuring that the residents who are being impacted heavily by COVID-19 are still able to obtain the same services and level of services and resources to ensure a healthy DC. So thank you for having me.
Thank you so very much, Dr. Gray. We would like to continue with Mr. Anthony Gutierrez.
Good evening. My name is Anthony Gutierrez. I use he, him, his pronouns. I am the community liaison with Gilead Sciences. I have about over 13 years of work doing HIV work, primarily in communities. I'm the HIV community liaison for DC and Virginia. I started my career in HIV as an HIV counselor and tester. So my experience comes from kind of grassroots mobilization and outreach. I went back to school, got my master's in clinical psychology, and have held various positions in the HIV field. So with regard to that first question with what do I do on kind of a community advocacy level to make certain communities aware of their vulnerability, especially those who are disproportionately impacted by health disparities like HIV and COVID. I think that one of the most important things that I learned early in the HIV work and what keeps me engaged in public health and HIV work is that you can't do HIV without doing social justice work. And I think that's larger and broader when we talk about public health work. So when I approach public health, when I approach HIV education, I approach it through the lens of social justice. And I think it's also important that when we talk about health disparities, that we also keep in mind the stigmatization that can come with that. And anytime I talk about certain individuals being of higher vulnerability, and I tend to try to use less stigmatizing language, I found that when we talk about risk levels, that can sometimes feel stigmatizing, as if someone's doing something or deserving of some health inequity. So I tend to use the word vulnerability as a way of showing that it's not because of individual behavior. It really has to do with structural and social determinants of health. That we see higher rates in certain communities, not because those communities, by any volition of their own, put them at higher risk. It's the system that has put them at higher risk. It's poverty that's put them at higher risk. It's access that's put them at higher risk. It's all these sort of barriers to healthcare that have created situations where certain communities are more vulnerable to certain diseases like HIV and COVID. So I think that's one of the biggest things that I do when I do any type of educational talk is, one, try to get the information out there, two, really look through it through the lens of social justice, and three, make sure that when I talk and when I give this information, it's keeping in mind that I do not want to further stigmatize our communities, but really sort of empower them and be very sensitive to the fact that we are at higher vulnerabilities, not because of something that we're doing, it's because of the system that we're in.
Thank you very much, Mr. Gutierrez. Now, next, could we please have Dr. Nicole Rochester?
Hi, thanks for having me. So I'm Dr. Nicole Rochester. I'm a board certified pediatrician with over 20 years of experience. And 3 years ago, I transitioned to become an independent health advocate and founded my company, Your GPS Doc. And that transition was prompted by a caregiving journey with my late father. And what I learned as a caregiver is that patients and family caregivers are often not listened to in medical settings. I had the opportunity to experience our healthcare system from a completely different perspective. And what I know is that your ability to be a strong advocate for yourself in healthcare settings absolutely changes the amount of care and the quality of care that you receive. And so as a result of my personal experiences being a caregiver for my dad and being able to be an effective advocate for him, largely because of my medical background, I now help other, normal everyday people navigate the healthcare system. And so in answer to the question about, working with at-risk populations, vulnerable populations, knowing that our ability to take charge of our own healthcare, our knowledge about not just our diseases and our chronic conditions, but actually knowing how to navigate the system that is stacked against us is incredibly important. And that's what I do through my company. Through a lot of it is through education and health literacy, making sure that individuals understand their medical problems and empowering them to be advocates in medical settings, empowering them to be comfortable asking those important questions, speaking up when they don't understand what the doctors and the other healthcare professionals are saying, and then having a knowledge about the system itself so that if they are meeting barriers or if they feel that the care that they're receiving is not appropriate, giving them the tools to be able to navigate that situation as well and to be able to escalate their concerns.
Thank you so very much, Dr. Rochester. Next, can we please have Mr. Damon House?
Strategy for healthcare within Microsoft's Worldwide Services division. But my real passion is around communities of color. And I work at the intersection of education, innovation, technology, industry, and even entrepreneurship. So Dr. Rochester, in starting her own business, is doing what is needed in our communities to further help with some of the disparities that we're seeing. In my day job, some of the solutions that I manage are virtual visits and virtual clinics, and also health bots. Those are two solutions that were used a lot during the last year, including by TSA and CDC here in the US, but also in a number of other countries. We found that our ability as a healthcare system, it was just really on the razor's edge. And when we started dealing with the pandemic, it was very difficult for us to reach a lot of those patients, especially in communities of color. So when I address this question about how can we better provide information, provide infrastructure, and provide solutions for our community. I look at it from a number of factors. First of all, we need to have better research on how we got here. The disparities and the comorbidities around things like diabetes and hypertension, how those were impacted by food insecurity and food availability and sustainability in our communities. And so I'm working to further research in that aspect. I'm also looking at the intelligent supply chain. It was broken. I mean, it worked just well enough, but as soon as there was a crisis, it fell apart. And it fell apart most noticeably in our communities. And so I've been looking at how we can bolster and strengthen that to ensure that we're able to get the supplies that we need when we need them. And then lastly, much more broadly, I'm looking at the vaccine. I actually have a solution around vaccine registration and administration. I know we're going to talk a lot about this tonight, but we have to convince people that the vaccine ain't gonna kill you. The Rona will. We can, that's a challenge that we have to get people to understand. We have to get them to not be afraid of the cure, as our former president was talking about. But we have to help them to understand that receiving the cure and participating in that helps our communities to improve and get healthier. So thank you for the opportunity to share the stage with some really great speakers tonight.
Thank you very much, Mr. House. I would like to ask Dr. Earl Etienne to comment next. Thank you.
For having me here this evening. I will take just a slightly different tack. Just by way of introduction, I'm the Director of Graduate Programs and Industry Partnerships, and I'm a professor at the Howard University College of Pharmacy. In terms of training, I graduated from Howard University as a pharmacist, did postgraduate work at Mount Sinai in New York in clinical and administrative pharmacy. I hold a master's in business administration and a doctorate in law and policy. So I tend to look at things from the policy slant in a lot of cases. We look at policy and then we look at operations. And if you would just bear with me for a moment. Dr. Wilson, you talked about health disparity and the definition, and we keep hearing the term health disparity and so on. What we need to really be concerned with starting out this process is really understanding the definitions, okay? And when we speak of health disparity is really a difference in the health status that is closely linked to a person's social, economic, and environmental disadvantage, okay? But then you hear of the term health equity, right? And that means that everyone has a fair and just opportunity to be healthy. So while we have health disparities, we need to be concerned with health equity as well. But within that mix, there's healthcare disparity. And healthcare disparities really refer to the differences in the quality of healthcare provided that are really not due to access-related factors or clinical needs, or even the preferences or the appropriateness of any intervention that's put forward. What we have today, I think, is an issue of, one, education. We have an issue of access. And we have an issue of really people being in a position where they do not believe because of historical wrongs that have been done. Based on what the question asks, what are we really doing at our institution here at Howard University? I have to commend the leadership for the approach that the leadership has taken. The president came forth and set out a very clear plan for what's going to be happening at the institution. He laid out guiding principles. He laid out principles surrounding campus visitation, health, wellness, what we will do with the employees, the residence life, the dining hall, everything that you could possibly think of were taken into consideration in terms of laying out the plan for the institution. If we are to assist the community, we have to be sound in that community. And so he ensured, along with his team, ensured that, one, we knew exactly what it is we were doing and how we were going to tackle this issue. We have a special place in the community as a university. We have a place of trust, and we have to ensure that we in no way compromise that place of trust. So once we got our house together in conjunction with the CDC guidelines here, what we did, we partnered. We created testing sites. We created vaccine administration sites, focused really on the individuals who needed it most. So there was a site created for elderly and poor residents who are 65 and above. We also went to those individuals. So the College of Pharmacy set up testing centers in communities that would normally not get out to get testing. So we have to really take this as a holistic approach. And Howard has a special place. It's near and dear to me. It's near and dear to a lot of individuals in this community. And we understand what the disparities are. We understand what the historical perspectives are surrounding vaccines and treatment. And we have to care. And if we care, then we can communicate, then we can educate. And I believe we stand good and ready to do just that.
Thank you very much, Dr. Etienne. Indeed, health disparities and health equity are a multifaceted issue that will require, approaches and solutions that address all of the facets. And lastly, but not least, we'd like to have Dr. Jacqueline Miller.
Good evening, everyone, and thank you so much for having me be a part of this panel. So I am a pediatrician by training, but 20 years ago, I began a career in vaccine clinical research. So put simply, my job is really to research vaccines, generate the right science to inform regulatory agencies like the FDA about how well vaccines work and about their safety profile, to talk to agencies of public health like the CDC who are thinking about vaccine implementation programs, and to participate in discussions such as this one to really talk about the vaccine science and communicate the facts about what we know about the vaccines. And so I feel that in doing that, I'm really doing my part in making sure that people can make an informed choice about the best healthcare decisions for them.
Thank you so very much, Dr. Miller. With the conclusion of that first round of test questions, I would like to extend the invitation out to viewers of our event this evening to submit questions and submit comments at your discretion for our panelists. The intent is to get feedback from our audience and to answer questions from our audience, as many as we can. We do have some prepared questions, but we are encouraging members of our audience to submit questions as well. So with regards to our next question, we will look in our next segment, we're looking at hesitancy and history. And our question for this segment, our first question for this segment is, from your perspective, what is the leading contributor to hesitancy with regards to vaccination? And first off, with this question, we would like to hear from Mr. Gutierrez.
Yeah, no, thank you, Dr. Wilson, for that question. And I think Dr. Etienne was getting to kind of the root of that, and it being really kind of that historical mistrust or distrust. And, I like to say distrust as opposed to mistrust, because there's been some real ethical violations of that have been committed within our communities that have to be acknowledged and spoken about when we talk about getting our communities to engage in health. So I think that's one way, is that if we're going to ask our community en masse, and that's what we're doing, to engage in this healthcare intervention, which I wholeheartedly believe in, we also have to address the quote unquote elephant in the room and understand and put that in perspective. I also think, and this was mentioned too, we have to do this and utilize this as an opportunity for health literacy, right? We can't just talk about the vaccine in the vacuum. We really have to talk about the importance of healthcare engagement and what that looks like. And understanding, prior to us kind of jumping onto this segment tonight, there is some, backstage talk about, individual family members engaging with the vaccine. and questions they had, and really not even understanding how vaccines work, right? And I think that's part of the issue. And when we think about why is our community aware of more simple medical science, and I think it has to do with the denial of access, and not just access as a patient, but access as a contributor of medical knowledge, right? I think about my own family. I'm the first one in my family to achieve a higher educational degree, right? So there is no one in our family, our friend group, who had a master's degree or a bachelor's degree, more or less a medical doctor, right? My sister married her long-term boyfriend, who they were, high school sweethearts, and he is now a doctor, right? He's now a medical doctor. And all through his process through medical school, he became the go-to for my whole family, grandparents, aunts, uncles, cousins, everybody was calling him about, oh, I have an ache, or I don't understand this. And now that he's a doctor, they call him up. But that's part of access, right? That's part of understanding and knowing and trusting medicine. The fact that there are so few Black and brown doctors means that there are so few families who have that type of access. And when we think about our white counterparts in this country, how many of them have a family member, be it an aunt, uncle, distant, or friend who's a doctor or a nurse practitioner, right? That they are used to calling or talking to, that they get this medical information, not in a doctor's office, but on the couch or across the dinner table, right? And our communities have been denied that type of medical access. So when we think about why the hesitancy is because this hasn't been part of the fabric of our family and of our community engagement. So when we talk about how do we get information out to our community, it's not going to be in the doctor's office, and it's not going to be in an academic setting. It's got to happen at the dinner table. It's got to happen on a one-to-one relational, and it's got to happen en masse if we want our whole community to engage. So I really think it has to be addressing historical violations and getting health literacy kind of infused into our community. Talk later about, suggestions or ideas about how we do that.
Thank you, Mr. Gutierrez. I'd like to continue on with a response to this question from Dr. Gray.
Thank you. So I definitely agree with much of what Dr. Etienne and Mr. Gutierrez has, clearly stated that, definitely health literacy is a very key component to getting people to, want to trust in the system and trust in the vaccine and in the treatments related to COVID-19. But also along those lines, also the way in which information is delivered. I think one of the biggest challenges since the beginning of the COVID-19 response, even prior to thinking about, vaccines or vaccine hesitancy, is there's a lot of information, and trying to decipher and filter through all of the information that is constantly sent out through various channels can be overwhelming for many. And so, the trust also doesn't only, or the distrust doesn't only necessarily just lie within certain populations, but it also exists with even our public health and our healthcare community as well. And so it's very important to have forums like this one where we can truly openly talk about what have been some of those longstanding issues, what have been some of those longstanding barriers that are keeping people afraid and concerned. It's also important too that as public health professionals, or those of us in this, in healthcare and education, be open-minded as well to those concerns and address those concerns openly. It can be that we want everyone to go and get the vaccine or to receive treatment, But it's also very important to talk about and acknowledge the fact that people are afraid and that people are concerned. And we can just, our goal is really to be able to present them with information in a way that they can understand, bringing it down to where, relating it to their families and their friends and those that they care about, and reminding them that of the bigger picture and the bigger goal, that it's about about health and improving health and well-being of those within our community as well.
Thank you so very much for that response, Dr. Gray. I want to again encourage viewers, participants in the audience to submit questions that you may have for our panelists. The intent is for this event to be as interactive as possible. And so for this segment, we're going to wrap up with Dr. Rochester.
Yes, I definitely agree with everything that has been said. I do think that trust is the primary factor that leads to vaccine hesitancy. And I think it's important to acknowledge that, this distrust is not simply from the history, from the slavery and medical experimentation and Tuskegee and Henrietta Lacks and all of the things that we hear repeatedly on the news stories when they talk about vaccine hesitancy in communities of color. We have modern day examples. I mean, I don't know a Black person who has not either personally had a negative experience with the healthcare system, or their mother, their father, their sister, their brother, their best friend. And so, the reality is that these things are happening right now, today. And, this pandemic has really kind of aired the dirty laundry of our healthcare system, and it has exposed current day issues with racism and bias. And, the reality is that we have not been treating Black and brown individuals with respect and with dignity in the healthcare system. And so now we find ourselves in the middle of a pandemic, and we want them to trust the information that we provide, trust the, vaccine and all the other therapies. And, people care about what when they feel that you actually care about them. And so we have a lot of work to do in this healthcare system. All of us have a lot of work to do, and we have to really regain that trust. And, I'm hopeful that it's going to happen, but I don't think that any of us should be surprised about the fact that people are hesitant about getting the vaccine. And I'm thankful for platforms like this so that we can just continue to share accurate information and, help our communities get closer to a yes.
Yeah, that is a very good point. Thank you very much for that, Dr. Rochester, with regards to not needing individuals in vulnerable communities and high risk and underserved and underrepresented communities, not needing to look at historical examples. You can look at current day examples. There have unfortunately been some of those examples that have been, relayed in the media recently. We have had some questions from the audience, and we want to try to take a look at some of those really quickly before we continue on. One question that we have says, I'm allergic to penicillin and any sulfur type of drug, excuse me. And the question is it safe for me to get the vaccine? We can have anyone who would like to offer a response to that.
So Dr. Wilson, I'm happy to speak to that. And I'm going to speak about both of the vaccines that are currently authorized. So both of them are the messenger RNA-based vaccines. One is from Pfizer and one is from Moderna. And the contraindications to vaccination include individuals who have allergies specifically to components of the vaccine. So the questioner has asked about components of other antibiotics. And it's an excellent question because it's not always clear to people what ingredients in antibiotics and vaccines and other kinds of medical products might be common. Penicillin and sulfa are not used in those two vaccines, but the best discussion and the best place to get information is to have a discussion with your trusted healthcare provider. That's because your healthcare provider really knows you and your health history best. But to speak to the reports of anaphylaxis that you probably have heard about on the news with the vaccines, again, the background rates of anaphylaxis in use with the vaccine have actually been dropping from the initial reports. And the vaccination clinics are all recommended to have the ability to treat anaphylaxis should it occur. So something else you need to know is that anaphylaxis is very treatable with epinephrine pens. So in conclusion, I think the best thing is to have a discussion with your healthcare provider, but those specific allergies, penicillin and to sulfa drugs, is not a specific contraindication to either vaccine that's currently authorized.
Thank you so very much for that response, Dr. Miller. There is a second question as well, and this question is asking about the vaccine with regards to how it compares to flu vaccines, and seeing that flu vaccines are essentially administered seasonally every year, and is some question about the content of the SARS-CoV-2 vaccines in comparison to flu vaccines. And again, anyone else, you feel free to answer that one as well if you'd like.
Okay, sure. And maybe actually, Dr. Wilson, this would be a great time to talk about what is in the mRNA vaccines and how they're different from other vaccines. I know that was one of the topics we were actually going to come to later, but it may help to answer that question a bit. So messenger RNA vaccines, they're newly authorized. So it's the first time these types of vaccines are being utilized. But I really would like to emphasize that they're based on a fundamental biology that's been known for quite a long time. So messenger RNA for at least 60 years has been known to be able to induce cells to make proteins. It's also been known to be able to induce immune responses for the last 60 years. So what's really new is our ability to utilize that technology. So what is mRNA? Everyone has heard of DNA. That's what our genes are coded in. And you probably have heard at some point that your genes are very tightly held information by your cells in the cell nucleus. The messenger RNA really serves as the manual that translates that DNA blueprint for every cell, every protein that your cell makes. The messenger RNA is the molecule that really enables your cell outside of the nucleus to be able to make the proteins that your body needs for every aspect of its day-to-day living. So including proteins that you've probably heard about every day, like insulin, like hemoglobin. These are all proteins that are encoded by your DNA. One of the things your immune system does is takes the foreign viruses and bacteria, like influenza and the SARS virus, takes it inside the cell and really processes those proteins so that the immune system recognizes those proteins. Messenger RNA just does the same thing. It codes for the key proteins of the virus, but it does it without including all of the other aspects of viruses that make them transmissible from person to person or allow them to spread from person to person. So if you think about other kinds of vaccines, like a varicella vaccine, that's a weakened chickenpox virus that protects you as a child from chickenpox. So it still has the ability to do some of those aspects of viral biology. mRNA takes that one step further and takes out all the other aspects of being a virus. So really, this is just the messenger RNA, which all of your cells have, a blob of fat to protect that messenger RNA from the way that your body has to quickly break it down. And it uses that messenger RNA to make the right protein to induce the right immune response without ever having the viral infection. So how is that different from a flu vaccine? It's different in a couple of ways. The flu vaccine is another vaccine where influenza virus is actually grown up in egg cells. So that's why you may have heard that people that have allergy to eggs shouldn't get flu vaccine. There are still some aspects of the virus that are present in the flu vaccine, although it's completely inactivated, and you don't get influenza from getting a flu vaccine. In a similar way, you don't get COVID-19 from getting one of the COVID-19 vaccines, but this isn't a virus that's ever grown up in egg cells. It's completely separate from that, and a little bit closer to other kinds of vaccines that are simply a protein, like a hepatitis B vaccine. The other big difference between a COVID-19 vaccine and a flu vaccine, you get a flu vaccine every year because that flu virus slightly changes year on year, and your immune system doesn't quite keep up with those changes. So it's why you need a booster to help your body recognize those small differences in flu virus year on year. SARS-CoV-2 was a completely new coronavirus for humans. And so at the moment, we're just trying to get everyone with their first vaccine to get some level of immunity on board. You may have heard that there are some variants of that virus that are now being reported. So that's a big story in the news these days. And I think it's still a little bit early to know whether we're always going to be able to use the same vaccines or whether we will need to use boosters every year or several years in order to protect us from those changes that may happen in coronavirus. So I hope I've answered your question. I know that was a very long-winded answer, but I'm happy to answer follow-ups if they are there.
I think you did an excellent job of pointing out some of the key differences between the coronavirus vaccine and the flu vaccine. Thank you very much, Dr. Miller. With that answer, we are going to move on to the next of the prepared questions that we have for our panelists. And the next question is, what policies or strategies are currently in place within your institution or organization to address vaccine hesitancy? And we want to start on this one. We're going to ask Dr. Etienne to lead us off. He's muted.
And I want to commend the group for putting this panel together. As an institution, I will take the opportunity again to sing the praises of the administration, the president, the provost, and the task force that have been put together to really address this issue within our community. I have a few things that I would say. One, the university adopted a position of transparency. Okay. The leadership wanted to ensure that everyone knew exactly what was happening, so that we can dispel any myths that was out there. Sometimes you can't help, based on your experience, to be skeptical about things. Okay, so you would have seen that the president and members of the senior staff got out in front on the news, on the different programs, talking about being participatory in this process. We advertise the fact that we are involved in some of the clinical trials associated with this. We said to the community that trust what we say, that yes, we believe in vaccinations, we believe in really being there for the community. I think probably what happens is that people don't necessarily always understand how vaccines work and how the immune system works. And that sometimes creates some, dissonance. Okay, and we have to do a better job, globally in really communicating how the immune system works. And if I would just take a second and say, when your body's exposed to a pathogen, something that could possibly make you sick, you have two parts of the immune system: the innate and the adaptive. Right, and when your body's exposed, the innate system quickly rushes to that pathogen, right? But the adaptive immune system is also there working, and it goes to that pathogen. But the adaptive immune system has a very long memory, for lack of a better term. And when the body's exposed to that pathogen later on, it will indeed fight that pathogen, because anything that is foreign, right, is considered dangerous. That's how the body sees it. Okay, so we have to do a good job with education, and I think our administration has done that. Participation in clinical trials, being there in the forefront to tell our students, to tell our customer base that we are indeed involved in this process, and being very transparent with it. As a pharmacist, we are one of the most accessible healthcare professionals in the United States. There's a pharmacy within 4 miles of every American. Okay, now that could be further in some of the rural areas and so on, but we're still the most accessible healthcare professional. And we were open during the pandemic all the time, and people have access. So we have to use that information to be able to really communicate the information necessary. So as a college, we went into the community, we went to the people. Okay, we had vaccine and testing sites that were stood up so that individuals they're always comfortable with us now, so they're likely to listen to us when we give them that information. And the university took advantage of that by saying, hey, listen, let's be on the forefront of this. Let's go into the communities that are typically not addressed. In Washington, D.C., those being, east of the river and so on. So we have to do that. I believe nationally, we have to have solutions from the community so we can have a bottom-up approach, and it shouldn't just be top-down. If we bring the solutions from the individuals who need to be treated, those individuals will provide us much better solutions than if we try to drive solutions to them. I say to individuals, and I've been asked this question, well, why should we take this vaccine? Why don't they go and test it in the rich zip codes? And I made a statement. I said, listen, look at the uptake of the vaccinations in the rich zip codes, and then you tell me what's the difference. We've seen across the country where the wealthier populations are getting the vaccine. So do they know something that we don't know in the disadvantaged communities? Okay. So we need to be able to take our cue from what's actually happening in reality. As an institution, I'm humbled, and I am proud to know that Howard is doing what needs to be done in the community to ensure that we take care of our patients.
Thank you very much for that response. I think you did a very excellent job of highlighting that this is a multifaceted issue, and that we have to address all of the aspects of the issue to really make a change, and impact the issue with regards to education, whether it be on just simply how the immune system works, and complementarily how vaccines work with your immune system, as well as that transparency in order to maintain the trust in the community that you're looking to engage. Thank you very much. We would actually like to ask Mr. Gutierrez to respond next. And it is my understanding that we're experiencing some issues with our video, and we just want to apologize for that to our audience, and we are working to resolve those as quickly as we can. And I just got word that we have resolved those issues. So great. Thank you. Mr. Gutierrez, would you please respond to that?
Absolutely, and thank you for the question. So I'm going to respond to the question, not necessarily what my institution is doing, but in a broader sense of what we can learn from the decades of doing HIV work and advocacy, because I think there's a lot that we can borrow best practices when it comes to how we've been effective and how we're trying to reach those disproportionately affected by HIV, because it's the same populations, right? When we talk about who's disproportionately affected by HIV, it's Black and brown. So I think our first strategy is to do what we would call a culturally responsive approach, right? And so we can't just look at the information and say we need to give this out universally to everyone in the same way. we really have to look at who it is that we're talking to. And when we talk about culture, we're not just talking about race, right? We're also talking about neighborhood, and what makes up a culture is much more than just race, even though race is a big contributor of our culture, but it has to do with geography. It has to do with our parameters of where we engage and who the thought leaders are within our particular area. So whenever we're going to give information out, we need to do it in a culturally responsive way. The second thing that we've learned in HIV in a strategy, it needs to be very client-centered, right? So what that really means, it's relational, right? It's not a blanket campaign. It has to be really a one-on-one, meeting the clients where they're at, with the information that they have, with the hesitancies that they have, and really doing it on an individual level. I think another thing that we've learned from HIV that we could transport in this response is community health workers on a peer level, right? We need to hire, and I'm very big on hire, use some of that public health money to actually infuse into our communities that are disproportionately affected, give them the resources by educating them, making sure they're fully aware of how to answer questions, equipped with that knowledge, and then pay them to then go out into their community and their networks to transfer that information. This has been really effective in HIV. We've seen it be really effective in other areas of public health. And I think, it looks at addressing public health inequities on multiple levels, right? Poverty is one of the main drivers of disparities within public health. So employing people, giving people those resources, ensuring that we're not just asking for volunteers, but that we are actually paying people for their time. And then it's also giving that information in a way that's understandable, I think is translation, right? We have to translate medical information. So, I mean, those are the strategies that I think have made us successful in HIV that we continually look at, and things that we should look at when we think about the COVID response.
Thank you very much, Mr. Gutierrez, for that response. And lastly, for this question, before we head to some additional questions from the audience, Dr. Miller, would you like to respond to this one?
Yes, please. And I really want to build on some of the great themes that I think have already been developed by Dr. Etienne and Mr. Gutierrez. So one of the things that we knew going into the vaccine development for the COVID-19 vaccine was that it was absolutely critical that our clinical trials be representative of the communities that are impacted by this devastating disease. There really are differences between men and women sometimes, different racial groups, different age groups, and how they respond to medicines and vaccines. And we knew that it was not going to be terribly informative if we only have data generated from those populations that are not as impacted. So one of the things that our team did was engage in an inclusion and diversity advisory board. So really speaking to what Mr. Gutierrez was just referring to, recognizing that those of us who have a healthcare background, those of us who may not be living in the same communities that are disproportionately impacted, may not always understand what kinds of questions people have, what language we use that isn't terribly understandable to others. And while this advisory board didn't do the work for us, they helped us be a bit more culturally sensitive as to how we go about approaching clinical research with communities of color. And I just want to say that I think this experience has been an amazing one. It's been, to me, incredible how much we've learned from working with these partners, but it's only a start. And I think it's one of the things that we need to recognize as a priority moving forward as we develop other medicines and vaccines. They really need to have data in the populations who are most likely to be taking them. And so hopefully we can build on the success of the vaccine development programs through SARS-CoV-2 recognizing that we have quite a hurdle to overcome for all the reasons stated previously. So if anyone out there actually did participate in the clinical trials, I just wanted to say a huge thank you. You guys are the heroes to this whole endeavor that have enabled us to begin distributing vaccines across the country.
Thank you so much for that response, Dr. Miller. Just to share some of the comments that we are receiving in our chat, we got one comment that says culture and language matter, which is in fact is very true and indeed the case. And a follow-up question, so to speak, is what strategies should be used for ethnic minorities who are often lumped with Black Americans or African Americans, but often require more targeted outreach? And if anyone would like to offer a response to that question, we would love to hear that as well.
Yeah, I'll take a quick stab at that too, because I think that's a soft spot for me when we in public health will say Black and brown communities, or we hold programs for Black and brown communities. And really, when we talk about culturally responsive care, it needs to be very much focused on that particular community. And, you know, when we talk about in this country, racism spans, you know, every single ethnic group that I know of in the United States. And it really is a light dark racism. We were taught that, it's ingrained, it's our original sin in this country. You see that in Latinx communities, you see that in Black communities, you see that in Asian communities, that Caucasian white is considered to be supreme. And the closer you look to those features, the more benefits that you're given in our society. And it doesn't matter what your ethnic background is, it has to do with appearance. You know, and so I do think that we need to understand the nuance of how racism plays out in different cultures and in different you know, pods or whatnot, communities. But I think we need to be very intentional when we do culturally responsive care, that we look locally and we find that out, and we don't impose sort of blanketed approach for, you know, large blocks of geography for a whole state or for a whole country with regard to a particular population of focus.
Thank you very much for that insight into some of the nuances that we kind of tend to overlook at sometimes, right? As you mentioned, between some underrepresented communities and when they get lumped together. We have an additional question from the audience that I'd like to pose, but it's one that I could potentially field. The question specifically asks, I'm asking on behalf of a patient who had a bad reaction to the hepatitis B vaccine. How can they obtain a waiver for the COVID vaccine? So that seems to imply that there's some belief that you must get vaccinated with the COVID vaccine, and there is no mandate from far as I know that requires anyone to be vaccinated with a COVID vaccine. And it's these, as Dr. Miller mentioned, these vaccines are under what is called emergency use authorization. And that is because this virus, SARS-CoV-2 virus, is fatal in some cases to individuals who have pre-existing conditions, and it is being used in an emergency manner to prevent severe illness and death in the general population. But there is no current mandate to take that vaccine, take the SARS-CoV vaccine. And with that being said, I will continue on with our next of our prepared questions. And this question is, what type of partnership or strategy would you recommend to improve awareness, education, and engagement of high-risk populations, and to increase understanding and improve vaccine uptake? And for this, I would like to start off by hearing from Mr. House.
Thank you. And this is a fantastic question. It was mentioned earlier by a couple of the speakers, including Dr. Etienne, that HBCUs and minority serving institutions overall have the voice in our communities that are listened to. When we talk about HBCUs in DC, in Atlanta, in Nashville, in Los Angeles, and in these Black serving, African American serving institutions, tribal colleges and universities on Native American and indigenous population reservations, Hispanic serving institutions, we speak the language of the community. We can talk to them about the historic implications of our shared community, our shared past and history. So that also extends to outside of these areas. When we talk about a Grambling State or a Tuskegee or some of these schools that are in those communities where there may not be a major hospital for a good distance. This is the voice that people in those communities can hear. And so we must partner with them. We must align with them to make sure that they have the information, they have the voice, and they're providing it out into the communities in an effective way. We should also help in that communication and talk about the short term and the long term. Yeah, there are a lot of people who think that this stuff is going to get fixed immediately, overnight. We're going to get everything solved in a couple of months. And yes, we can get shots in arms, and that's the vaccine, but helping to dispel some of the mistrust and in some instances, the distrust in these communities is going to take a lot longer. We must start addressing the comorbidities in these communities, in our own daily lives, in our familial lives, and in our community. We must help people to understand that I, as an individual, unless I believe that there is a reason why I shouldn't, getting that vaccine helps to protect me as an individual. Then that helps me to start interacting with my family, older generations, younger generations, those who may be around in my bubble, and then into our community. So that when we go into a grocery store and we sneeze, we're not impacting those people who are around us. Pharmacies, and especially independent pharmacies, are also a weapon that are not used as frequently as I would like to see. I want to see it. We know about CVS and we know about Walgreens, but those minority pharmacists that graduate from a Howard University, from a Xavier, from a Texas Southern, must be employed as weapons that we can go out and we can fight this distrust, where we can fight the lack of that access to these drugs. I can tell you from firsthand knowledge that when we go to majority communities, there are actually people who are sitting in their homes and the vaccine is being brought to them. And that is fine for them, but what's going to happen for us? And so we must make sure that we're using all of the partners that we can, all of the strategies that we can to educate, to inform, to empower, and to engage so that we're getting the best results possible.
Thank you very much. Yes, and that dovetails into Dr. Etienne's comment earlier regarding pharmacists being the most accessible. And they're most accessible, but yet potentially the most underutilized healthcare professionals that we have in the team, with regards to the team of healthcare professionals that we encounter on a daily basis. Thank you very much for that response, Mr. House. And now we would like to get Dr. Miller to weigh in on this question, please. Thank you.
Sure, and so thanks so much, Mr. House, for that that backdrop, because I think maybe I can build on some of the things you've said. So one of the other things that we've reflected on through the course of development of our vaccine is that people really prefer to hear about clinical research and what they might contribute to bringing medical technology forward for their community and for the rest of the country and the world, from people that they trust and that look like them. And so part of diversity and inclusion is not just diversity and inclusion in clinical trial subjects, it's also diversity and inclusion in the investigators. So, one of the things that we've tried to do is encourage physicians that are providing care to their communities who may not have considered vaccine research before to maybe think about engaging in that aspect of clinical practice. And there are certainly things that those of us who do this for a living can do to help make that easier. I think training in good clinical practice and in what regulatory agencies expect when we conduct clinical trials, helping to give advice about what kinds of resources you need to make sure you have in order to make sure that clinical research can be conducted safely and all of the elements can be maintained. So I think really diversity and inclusion is a theme that needs to really echo across drug development. So from the patients that participate in our clinical trials to the investigators, the physicians who do the overseeing of the safety of the trial as it progresses and their patients in it. And importantly, the study staff, the people who are really speaking to the patients on a regular basis.
Thank you so very much for that response, Dr. Miller. Indeed, to get more clinicians involved in the clinical trial process from the role of investigator would help to engage more members of minority communities to get involved with them as well. And at this point, we are going to actually switch to another question that we received from our audience. And that question that's posed as, is there anything being done with church leaders to help educate our communities on the importance of these vaccines? Would you, Dr. Rochester, would you like to take that one?
Sure. Yeah, I'm actually very encouraged by the partnerships that I'm seeing between the medical community and the faith-based community. I have seen myself lots of webinars that have been sponsored by some of the large religious denominations, large, church organizations and other faith-based organizations, where they have had webinars similar to this one, where they have pastors and other leaders within the church, partnered up with physicians and pharmacists and scientists and other healthcare professionals. I know that Dr. Fauci himself and even Dr. Kizzmekia Corbett have made their rounds, and I've seen them in some of the webinars that have featured faith leaders. So I do think that there is a recognition, particularly within the Black community, that the church is important, that pastors and other religious leaders are still trusted individuals in our community. And so I'm thrilled to see that partnership. A lot of hospitals are partnering with churches as well to distribute the vaccine. And we have some evidence of that right here in Maryland, where I am. And so I definitely think that there is a recognition that, it's been mentioned tonight about trusted messengers and people who look like us and how important that is to those in the community. And so I am seeing those partnerships between church leaders and medical leaders. And I'm excited about that. And I think that we need to continue that even beyond the coronavirus vaccine. I think that that is a very effective model that we need to utilize in healthcare moving forward.
Thank you so very much, Dr. Rochester, for the response to that question. We're going to pivot back to Mr. Gutierrez to respond to the last question about partnerships in the community.
Yeah, I think this is another one where HIV has kind of done some trailblazing with regard to what we consider untraditional partnerships, or partnerships outside of the ivory tower, which is, going to barbershops and nail salons, going to places where our community gathers. Churches, obviously, a big place. And I know that while we are meant to be doing physical distancing, sometimes that's a convenience that certain communities don't have, right? And so finding out where our community is convening during this time and really getting those individuals who are the clerks and who are the frontline individuals involved in that partnership, right? Once again, utilizing them as our outreach arm. And I do think that's going to be a key element to this, is doing outreach And it's not outreach necessarily from universities and hospitals. It's got to be outreach from the places where our community engages. And while we have some wonderful institutions that are kind of parked within or represent some of our communities, there's still a hierarchy, right? And our, with regard to resources within our communities. And so not everybody still trusts those institutions, even if they're representative of our community. So it's still important that we go on the ground level, that we don't forget about where our community engages and partner with those individuals. And I think HIV has done some really good work in doing things like that, and we can really look to our that public health industry to learn some of those best practices.
Thank you very much for that response. Highlighting again, I think engaging the community where they are in terms of outreach programs to again meet the community in a place that they're in an environment that they're comfortable in, and to meet them there to help address the issue. I want to turn back to some additional questions that we're receiving from the audience, and we have a couple of questions that are somewhat related. These are questions about single-dose vaccines that are available or that have been inquired about. And the question is specifically, what are your thoughts on the Johnson & Johnson single jab vaccine? And another similar question, what are the thoughts on the single-dose nasal COVID vaccine? We're glad to hear from any of our panelists that would like to respond to this question.
Well, I can address the Johnson & Johnson vaccine. That one just went to the FDA, and I think we heard reports earlier this evening or this afternoon that the FDA has determined it to be safe and effective. So, I'm expecting the emergency use authorization will likely be granted in the next probably few days. If we look at the data from that vaccine, we have seen some concerns from the community because the current vaccines that Dr. Miller spoke about, Pfizer and Moderna, have 94 to 95% efficacy. And now we see, Johnson & Johnson, and people saw that it's being quoted as 66% efficacy. So I know I've gotten a lot of phone calls and text messages from friends and family members saying, well, this one isn't as good. And, I'm not going to get that one. I'm going to wait and get the other one. But what we're really telling everyone is to take whatever vaccine is available to you. And what we know with the Johnson & Johnson vaccine is that while the studies showed that 66% efficacy overall, when you look at severe disease, which is what we really care about, you getting severely sick, you being in the hospital, you being on a ventilator or dying, the efficacy for that vaccine is like 84, 85%. So when you look at severe disease, which is really the most important factor during a global pandemic, all of the vaccines, the two that are currently available, as well as Johnson & Johnson, which will, most likely will get authorization, are safe and effective. The other thing, of course, is because it is a single dose vaccine, it's going to really increase the capacity for us to vaccinate a large number of individuals much faster, because now we only need that one shot as opposed to two vaccines. So the reality is that no one pharmaceutical company is going to be able to vaccinate the entire United States of America. And we should expect that there will be other vaccines that come down the pipe. There are many other vaccines that are currently being studied. And, the FDA is not going to approve, even in an emergency situation, a vaccine that is not safe and that is not effective. And so when it's your turn, we really urge you to take the one that is available to you at that time.
Thank you for that comment, Dr. Rochester. And I think that you make a very important point in that these vaccines are the purpose of their use is to prevent severe illness and death. And if a vaccine can provide protection against that, I think that is the take home message in this, and that there are people who have lost their lives as a result of being infected by this virus, and that these vaccines are by and large effective against preventing severe illness and death. So that if you are fall into a category or a demographic of individuals who's at high risk, then it may be to your benefit to get vaccinated. In terms of, we have some additional questions coming in that I'd like to also pose to our panel. Next question that's coming from our audience is, how long is my immunity after having COVID? So I am assuming that this is referring to an individual who perhaps has been infected, tested positive, may have, gone through the course of the infection, and now they may be considering whether or not they need to get vaccinated. That's what I can kind of deduce or infer from this question, which is it's actually a good one. So would anyone like to tackle that one?
I'll say Dr. Miller.
I'm happy to. I just don't want to take up more than my share of oxygen in the room, but I'm happy to speak to it. So the data about how long after you have a natural COVID-19 infection, how long that immunity lasts, I think are still being generated. So it was a little bit shocking to me to recall that actually it hasn't even been a year since my office closed and we all started to work from home. So while it does feel like this pandemic has been endless, it's actually in this country really been ongoing for less than a year, which means that the data are still pretty young in terms of understanding how long over time that immunity might last. But that said, it does appear that after you've had a COVID-19 infection, immunity does last for at least 9 months. That's not to say that there aren't some people who have had a COVID-19 infection and then gotten a second infection. So that certainly has been reported. And the question of the variants, so these new strains of the SARS-CoV-2 virus that are beginning to emerge, further muddy that question, because the antibodies that you develop to one strain of the virus may or may not be effective to emerging strains of the virus, a little bit like the discussion we were having about influenza virus. And we just don't really know enough about this virus and how it behaves to really predict that into the future. I think for the moment, the CDC is not recommending getting screened prior to getting your vaccination. And in discussions with the CDC, there certainly have been people who have gotten vaccinated while having evidence either of prior immunity from an infection where they didn't have symptoms, and even some people who have had symptomatic infections in the past. And so I'm going to go back to something I said a little bit earlier. I think it's really important to have a discussion with your healthcare provider who really knows your health history, knows what risk factors you have to really help you make the best decision for you.
Dr. Miller, I'm going to move quickly to our next question for our panelists. And that question is, what do you think are the top 3 factors people need to consider when making their decision about getting the COVID-19 vaccine? Now, 3 may be a bit many, you can limit it to 1 or 2 if you'd like, but we'd like to start with Dr. Gray on this one.
Yes, I think one of the top factors that individuals want to consider is in line with what many of the panelists have said this evening. Is the goal is protection of not just yourself, but also of your family and loved ones as well. Our goal, again, is protecting yourself from acquiring severe disease. And I think everyone is eager and ready to get back to work and play, etc. And so I would urge individuals to consider the fact that, there have been a lot of work and effort into understanding the vaccines and understanding the technology that has gone into the creation of the vaccine. And so while I think many are hesitant, as it seems it's so quick, it's so fast, but these are things that have been studied for quite a long time. And a lot of care has gone into ensuring that the treatments and the vaccine are safe and effective for use in the population. So I would also urge individuals to keep in mind that it's quite all right to continue to ask questions, ask your providers, ask others in public health, and learn as much as you can in order to help you make that informed decision for yourself.
Thank you so much for that response, Dr. Gray. And yes, there have been lots of questions regarding how quickly these vaccines have been developed, and we could potentially, pitch a question to our panelists about that when we can get the remainder of our responses to this question. Dr. Rochester, would you like to respond to that one next?
Sure. I think one of the things that individuals need to consider, in addition to what's already been stated, is just the idea that we have to be willing to accept the unknown. I hear a lot of questions about, well, can you tell me that this won't happen? Or can you tell me what's going to happen in 2 years or in 6 months or in 5 years, if I get the vaccine? And, like it's been stated, all this is new. We are in the middle of a pandemic, and we're still actively collecting data. But what we do know is that COVID-19 is deadly. And what we do know is that despite the fact that, yes, the majority of people who die from COVID-19 are either older or have some underlying health challenges, but that certainly hasn't been the case for everyone. As a pediatrician, I can say that we have lost children to COVID-19, children who did not have underlying health conditions. There have been young adults who have died from COVID-19, again, some of whom did not have underlying health conditions. And then we also know that, there are people who are having long-term effects from COVID-19. And so we don't know a lot. We know a lot and we don't know a lot. And we can't look at you and say, you are not going to be severely affected if you get COVID. Many of my physician colleagues on the front lines are shocked every day at some of the patients who are either succumbing to this virus or who are having severe disease, long-term complications. And so I think that we all have to, acknowledging that this is all scary, acknowledging that there are concerns about the vaccine, we have to get to a place where we can be willing to accept some and understand whether they feel that, the risk of these unknowns outweigh the risk of actually getting coronavirus.
That is an excellent point in terms of the risk of an effect from a vaccine versus a risk of death. And that's kind of what you kind of have to weigh in terms of your decision and in terms of whether or not to get vaccinated. And lastly, but not least on this question, Dr. Miller.
You're muted.
She's muted. One second, Dr. Miller. I'm sorry, you're muted.
I knew I would do that at least once tonight, so sorry for that.
No
I think there were many important things already said about just understanding from your healthcare provider and the people around you what puts you or your loved ones at increased risk for severe COVID. And understanding those factors, whether it's your occupation, maybe you're a teacher who's around children who often don't exhibit symptoms and so can pass the infection easily. If you have older parents living in your home and knowing that age is the greatest risk factor for the severe complications of COVID, understanding those risk factors and having that conversation with your healthcare provider, other knowledgeable people, and your loved ones around you. I think will really help you have that discussion. And maybe if you don't mind, I'll also just take the opportunity to comment on the speed of development. So it is true that we have been able to pull together and mobilize to make vaccines available in a timescale that has been expedited compared to what we've been able to do in the past. But I think it's important to underscore that that was accomplished by a very unique collaboration between regulatory agencies, public health, government scientists like those at the NIH, as well as industry working together to go through the various phases of development. And by having independent review of safety all along the way, making sure that these trials were proceeding safely, but that sufficiently large safety databases had been generated at the time the vaccines were authorized. So the vaccines have all gone through phase 1, 2, and 3 of development, like other vaccines would go through. And the phase 3 trials for the vaccines under consideration in the United States all have had at least 30,000 participants. And those minimum criteria were really set by FDA. They're the measuring stick against which all companies were asked to measure their vaccine products. So it was mentioned earlier by Dr. Rochester that the FDA really does a rigorous review to make sure that the requirements have been met, both for how well the vaccines work, as well as ensuring an acceptable safety profile. So those things taken together have really enabled us to make the vaccines available, but also to make sure that we've generated the right science to have confidence in them.
Thank you for that. And in addition to that, there was one additional thing I read about in terms of how these trials are being conducted, and that normally you have each phase of the trial conducted consecutively, or meaning after phase 1 has concluded, then phase 2 will begin. And then subsequently, when phase 2 is concluded, then phase 3 will begin. Can you speak a little bit too about what was different in terms of how the clinical trials for the COVID vaccines were conducted in a little different way to help expedite the process as well?
Absolutely. So you're absolutely right that rather than doing things in sequence where one trial would follow the next, the trials actually were conducted in a staggered way, but also in parallel to continue generating that safety data in the most expedited way possible. But there were some checks and balances put on that system. So again, prior to enrolling in a much larger phase 3 trial, a minimum amount of, and by minimum, I mean a criteria was set for how much safety data needed to be available for phase 2 to feel comfortable expanding that enrollment into phase 3. And again, that was able to be accomplished by utilizing some innovative ways in which scientists that were not necessarily part of the trial and were independent were reviewing data in stream while the trials were ongoing. And maybe another important point is that the investigation of vaccines doesn't stop with the authorization. So as data continue to accumulate, as more people in the country continue to get vaccinated, you'll see that if you present for a vaccine, you'll be asked to report adverse events to the Food and Drug Administration so that they can keep monitoring the safety profile. You'll be asked to report adverse events to the various companies. So to Pfizer, if you get a Pfizer vaccine, or J&J, if you get a J&J vaccine, Moderna, if you get the Moderna vaccine. And that's so that we ourselves can continue to do our important due diligence to make sure that the safety profile remains favorable for the vaccines. And then finally, the CDC will invite you to join an application called vSafe. And this is actually a very clever application that will contact you on your mobile device if you have access to it, ask you some quick questions that you fill in. So the CDC is also looking at safety. And it's by having these overlapping mechanisms of monitoring that we hope to generate the additional data we need to continue to have confidence in the vaccines.
Thank you so very much for the insight on the clinical trials process and what enabled these vaccines to be brought to be made available so quickly. And that brings us to our final question for the evening. And this question is open to all of our panelists. And this last final question is, what is your top recommendation on on addressing reduced vaccine uptake? And we very much like to, get response to this from your respective, areas and from your respective fields, and look forward to getting your insight on this. So in terms of, really addressing this and ultimately for the benefit of the community. So anyone, please, I can call on you, or you can offer your response at your will.
Pick one.
Dr. Etienne, please be our guest.
I guess. Okay. So from the pharmacy perspective, I believe in collaboration. I think how we improve the uptake here is to really look at the past in some cases, right? With the opioid use disorder crisis, we had a biopsychosocial approach to really dealing with that, and we really dug into the communities. We need to do the same thing here. Where, from a pharmacy perspective, yes, we're the most accessible healthcare professional at this point in time, but pediatricians, in my opinion, have really learned and perfected the art of vaccinations. Okay. So therefore, if we're looking collaboratively, if pharmacists collaborate with pediatricians in the community, we can really do a bang up job in terms of getting uptake in that vein. People trust professionals that they know and have been comfortable with for a long time. As such, we need to pull individuals together and have ourselves do work collaboratively. The next piece that should really happen is we have to lean on the faith communities to say, hey, listen, we are in this together, and we need to really simplify the information so that the individuals within the faith communities can say to their members, this is what we need to do. Thirdly, one of my graduate students, we were working on a project looking at participation in clinical trials, and we looked at this from the standpoint of type 2 diabetes and individuals who had children with type 2 diabetes. And what we found in that, I can't give you all of the details, but one of the key things was really being informed. Did people truly know what the information was? And did they really care what the information was? So companies, organizations have to do a better job in terms of putting the data into the communities. The solutions for the communities have to come from the communities. So when we hear a lot of big organizations saying, we want to participate in this and participate in that, let's take the dollars and start the companies from the communities. Okay, so we take the individuals within the communities and say, hey, listen, this is something that will serve your community. How can you indeed benefit? How should we move forward? Far too often, we have been taking top-down solutions to solve problems that haven't worked. Okay, we have a social justice issue, we have a health justice issue, and to combat that, we have to take the people who have been negatively impacted and ask them to bring the solutions, even though we may think for a second that we have all of the solutions. So I say combine the pediatricians with the pharmacists, the people who know about vaccinations with the most accessible professionals, bring in the faith leaders in one group, and then take the individuals from the communities and use those individuals to be at the table with tangible solutions. People wouldn't feel that they are useful if they're not benefiting from the largesse that organizations may be able to provide when doing this stuff. We have to build trust. And the only way we can build trust is to include the people meaningfully who are being impacted by the process. So I wouldn't hog the mic. I'll turn it over to the next person. Brad, you're on mute.
Yes. Yes. In the practice of what's referred to as community-based participatory research, yes, it is. That's a central principle of engaging the community at the beginning, at the start of a research project, to get them involved and to get them to weigh in and to contribute into how that research project or study is designed, so that they feel that they have that they have a contribution. They're making a contribution, and that they're playing a role, and then they have investment. They're invested in it. Absolutely. Can we get Dr. Rochester?
I just love what Dr. Etienne shared. I think, just building on that, I think that the most important thing that we can do to address vaccine hesitancy is to listen. As was mentioned earlier, I think Mr. Gutierrez mentioned this. Black people are not monolithic. Latino people are not monolithic. Our Native American, indigenous populations are not monolithic. And so while we do have to address vaccine hesitancy in a mass format, we have to meet people where they are, and we have to have one-on-one conversations with people and really get at what their concerns are. If we just think that we know what's best and we craft these marketing messages and things like that, we're going to miss the mark. And so, when I have conversations with friends or family members or even people on social media who express hesitancy, I just simply ask them, what is your concern? Why are you worried about getting the vaccine? And I've heard a myriad of reasons, and then I can address that specific reason, which brings me to my next point, which is that I think that we cannot underestimate the power that we have with those in our circle. And like it was mentioned earlier about those conversations at the table, and really leveraging healthcare professionals with their circles. And then I'm finding that when I share information and when I debunk myths, then my cousin or my brother or my sister can then go and share that information with their friend group or with their coworkers or with their church members, and it has a snowball effect. So we can't tire in this mission, and each of us has a responsibility, particularly those of us in healthcare, to reach out to individuals in our circle, knowing that that information is going to travel much further than we could ever imagine.
A little each one teach one in there. Yes, a very, very tried and proven strategy. Mr. Gutierrez, could we get your response to that? This last final question, please.
Yeah, I think I agree. There's been some really great responses, and the only thing that I would add is to understand it's going to take all of those, right? And I think sometimes we get locked in and thinking, oh, I have this really good solution, and so I'm going to invest everything in that one solution. And it could be the best solution. It's not going to work for everybody. And so understanding that whatever approach we take, that we have to think of 20, 30 really good solutions and do them all. And really look at, not taking anything off the table when it comes to how we're going to approach this. We need to utilize, social media. We need to utilize pharmacies. We need to utilize colleges. We need to utilize everything, and not think there's going to be one answer to it or one panacea, so to speak. So, that would be my encouragement, is whoever's working on the front lines with this, that once you got a great idea, you appoint your point person, send them off, and then think of another great idea, and then send them off, think of another great idea, because it's going to take many, many great ideas to address this issue.
Thank you, Mr. Gutierrez. Excellent point that we must utilize multiple approaches, multiple solutions, multiple strategies to address this issue. Next, please, Dr. Miller.
Yes, well, I think Many great ideas have been shared. I think mostly I just want to say thank you to the other panelists, because I have learned so much about extending those listening pipes. And I think that's really where the core of it is. All of us wants to be listened to and heard, and certainly listening to the people who ultimately are going to be receiving vaccines or participating in clinical trials is probably the most important thing all of us can take away. And I guess maybe for listeners to say, when you're getting your information about vaccines and about SARS-CoV-2 or other health information, please just make sure you advocate for yourself. I think that's really the most important piece as being a patient, is to make sure that you have all of the information you need. And if you don't, please continue to ask questions. I think having a conversation is actually really the best way to come to a better understanding with each other.
That's fantastic advice. If you don't understand or have additional questions, do not be afraid to ask them and advocate for yourself. And lastly, but not least, Mr. House.
Well, and the funny thing is, I was actually trying to go first because I am not as smart as my esteemed colleagues on this panel. I just stayed at a Holiday Inn Express last night. When we think about really what this comes down to, it's been said a couple of different ways, and I think I want to just put a slightly different spin on it. We have to meet people where they are, and that's dinner table conversations, yes, but one of the important things that I think when we think about really what this comes down to. I'm sorry, there's a slight delay. Okay, so I think we need to make sure that we're addressing people where they are. It's not necessarily about having them go with the dinner table conversation, yes, but one of the important things that I think about. Okay, is there still an okay? Addressing people where they are. Wow, that's weird. It's like I'm hearing my voice from a year ago. We're asking people to get vaccinations at a lot of the hospitals that they don't trust. We're asking them to take the vaccines from organizations that they may not trust, like their municipalities. And so what we need to do is we need to figure out how to get vaccine pop-up stations in those community centers, like a university, like churches, where they can go and they say, I trust the organization who's bringing this pop-up opportunity to me. The second thing is Mr. Gutierrez was very eloquent when he talked about hiring people who can have these conversations. And when we're talking about HIV, which is something that is going to be here with us for a very long time, yes, hiring specialists on HIV makes all the sense in the world. But if we can effectively manage COVID-19, then there's an opportunity that it has a diminishing impact on our community. I would propose that we hire utility players. My sons play baseball, and so you can have superstars who hit, you can have superstars who field, but you need a utility person who you can plug in different areas. And those utility players are people who can understand COVID-19 very well for today, but then they're prepared to pivot for broader public health solutions down the line as new things may come up. And then lastly, it's been talked about data. I believe in data. And yes, we need to collect data, not for ill purposes, but if you take the vaccine and something goes wrong, tell somebody. Tell people that you know. If they get the vaccine and something goes wrong, tell somebody, because this is how, as Dr. Miller was able to say, we have to have that feedback loop. That feedback loop helps us then to understand on an ongoing basis what the implications of this could be. So those are the 3 points that I would like to make. I thank you for this opportunity to share.
Thank you so very much for that response, Mr. House. And I would like to take this time to thank all of our panelists for participating this evening. I think we did an excellent job of answering some questions, providing some accurate information, being informative, and engaging the audience of the program this evening and the questions that they had. And thank you all, including Dr. Gray, who had another obligation. Dr. Rochester, thank you very much. Mr. House, Dr. Miller, Dr. Etienne, Mr. Gutierrez, thank you so very much for your participation again. At this point in time, I would like to pass off to Ms. Cozy Joseph for our closing remarks.
Thank you very much. We wanted to take a minute to thank all our partners and sponsors, especially IndyGeneUS HRA, Morgan State University, Howard University, IOM, DHC, and in their efforts on this very important event. Thank you all to all the wonderful panelists. They were so knowledgeable and we learned so much from them. We've learned that despite the enormous effort in changing the landscape of healthcare inequities, much more work is needed to address the intersection of race and medicine. COVID-19 continues to be a threat to the US, hitting its 500,000 mark this week. As a collective community, we have a commitment to humbly serve those most vulnerable, to ensure that education and information to access the vaccine or overall treatment during this pandemic are readily available, and that their needs are met with compassion and respect. So we need to be that change agent and use our influence and our network to create the change we want to see. Please save the date for the next DHC Town Hall on March 25th. It's going to be between 4 and 6:30. We're going to continue to educate and share information with our communities. And this one will be on advancing women and girls initiatives through the diaspora actors in healthcare. For more information, please do reach out to HRA, and their website is www.hatirenew.org. Good night and be well, everyone. Thank you for a very informative and a very insightful town hall. We really appreciate your presence. Thank you.
Thank you.